All right, let's go on to oncology. So back to searching for a few diamonds in the dung, and oncology has got a lot of dung in it, and I love oncology, but for your purposes, there are a lot of dung here, and I don't want to turn you into oncologists. I want to turn you into folks who are going to get those 2 or 3 questions related to oncology correct. Okay, and remember what we said, this is my opinion, diamonds and dung is critical. As you're preparing, you got to find those diamonds, and as you're reading questions, you got to find the diamonds as well. So I'm going to review those content areas, and just like we did in hematology, you're going to pick some diamonds out from a lot of dung. Okay. Leukemia, lymphoma, brain tumors, solid tumors. Talk a little bit about survivorship. And then I think it's important to throw in a few not cancer questions. Okay, so 3-year-old boy, 2 weeks, lethargy and diffuse pain in his legs and arms. He's pale, he's bruising, he's got a 1-centimeter cervical node, and he's got a palpable spleen. Which diagnostic procedure or laboratory will provide you the most information? Okay, so let's see what you guys want to do. I want you to channel your inner Willie Sutton, okay? Where is the money? Okay. The money is in the bone marrow, okay? All right. So there are 2 things we're going to learn from this question. We're going to learn about dung, and we're going to learn about bank robbery, okay? So 1-centimeter cervical node is dung, okay? All right, that's not a diamond, and you don't want to touch that. For those of you who have children, well, heck, guys, we're all pediatricians, but especially you know this if you have children. You can find a 1-centimeter cervical node on what, 80% of 5-year-olds, 80% of a kindergarten class? I'm being silly, I don't know, but you can find them on a whole lot, right? So a small node in the neck is always dung. It's just it's not specific for anything. And the test that we want to do is the one where the money is. This patient has a diagnosis. They've got pancytopenia, okay? You got to be worried that their factory isn't working, and you need to do the test that goes and gets you information about that factory. Which of these following statements regarding leukemia is correct? Okay, AML is the most common child leukemia. The peak incidence in childhood is during toddlerhood, an age group that I think I defined. ALA, ALL, and AML are treated identically. It doesn't matter which one you have. It is more common in non-Caucasian children than Caucasian children, and there is a decreased incidence of leukemia in children with Down syndrome. So, I don't know how you guys would write questions, but I write questions. Sometimes it was very hard for me to get away from writing negative questions. Which of the following is not true? And one thing I liked about negative questions as a teacher was that it gave me an opportunity to put some important facts in front of you in that question. But we've been taught that the boards are trying to get away from negative questions, so I'm trying to get away from negative questions. So what we're going to do is we're going to take this answer and we're going to put a whole bunch of facts in front of you by correcting every answer. ALL is the most common childhood leukemia. Toddlerhood is where we get the peak incidence. You get another little peak in kind of the preteen years, but toddlerhood is where you see this. ALL and AML could not be treated any differently, okay? They are treated vastly differently. AML is much tougher treatment and a much worse prognosis. Caucasians are have a slightly increased relative risk when it comes to getting leukemia, and children with Down syndrome have a profoundly increased risk of getting leukemia, both ALL and AML. Okay. Leukemia is something we diagnose by doing the money test. We go to the marrow. There are two types in general, ALL and AML. ALL has a much better prognosis. AML can be weird. This is a disease where it can sneak into the soft tissue, sometimes the soft tissue around the eye, and cause proptosis. It can invade the gums and cause something that looks like gingival hyperplasia. Just strange presentations possible with AML. Nobody, not even the hematopathologists these days, like to try to tell them apart by just morphology. The one thing by morphology that can let you know that you have AML rather than ALL is the presence of an Auer rod. So this is a beautiful picture of a bone marrow aspirate, and it shows blasts, which are leukemia cells. And the way we tell a blast from other cells are that they're big, okay? They're much bigger than these red cells, okay? They have a high nuclear to cytoplasmic ratio. Where's that cytoplasm? Just these little rims of cytoplasm, right? Their chromatin is dispersed. And dang, we go up to, I take my residents up to look in the scope all the time. And what ideally, and maybe I'll just plop it down, for next year's group, I'll plop down a normal lymphocyte in the middle of this thing to show is that a normal lymphocyte has really condensed chromatin, okay? Like more, it's like darker and more, just clumpier. This chromatin is kind of spread out. You can almost kind of think of yourself as I can almost see through some of those blasts. You can also, if you look closely enough, you can definitely see that there are nucleoli present, okay? And so you're often going to see a lot of nucleoli. But the most important clue to making the diagnosis of leukemia, I think, is monotony, okay? All right? We have a lot of analogies. Probably the best one is the food analogy, in that a leukemic marrow looks like pea soup, okay? Everything looks the same, where a healthy marrow looks like minestrone. Lots of different vegetables, some other things, very, very different. Okay. You won't have to do this, but I love it. AML, there's your Auer rods. There's your ALL. Things are more dispersed in the chromatin. You can see it in both. They're not quite at the same magnification, but you tend to see a little more cytoplasm in an AML blast, but I guarantee you, nobody's going to call AML versus ALL unless they see those Auer rods. ALL, what are the facts you need to know about ALL? It is the most common childhood cancer. Almost 85% of ALL is what we call precursor B ALL. That means when that cell went rogue and became a blast and became a cancer cell, it was on its way to growing up to be a B cell. It was not a fully mature B cell. About 14% are T cells and 1% are mature B cells. That's the leukemia equivalent of Burkitt lymphoma, okay? Mature B cells. Mature B cells are going to mark for CD20, and they're not going to have some of the immature markers like TDT and all these other things in flow that I love to teach my fellows about. Epidemiology, 2 peaks. Remember, the big peak is in toddlerhood. Smaller peak is in that preteen, early teen years. They show up pale, they have fever, petechiae, they have pain, refusal to bear weight. Please, 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 always keep leukemia in the back of your mind with refusal to bear weight, okay? Both for exams and for life, okay? Labs, you can have leukocytosis or you can have leukopenia. And what that either means is that, the blasts have either, here's the marrow, here's the bone, marrow inside it, and the blasts take over the marrow, so they crowd out the healthy precursors, and therefore you're not making red cells, you're not making platelets, and maybe the white cells can be low. I've diagnosed plenty of patients who have low white cells and don't have blasts on their smear yet. The majority do have an elevated or white count, a mildly elevated white count, and you do see some blasts in the periphery, but you can have a leukocytosis, a big number, or you can have a low number, leukopenia. Sometimes you can get, abnormalities in chemistry, uric acid, which could be from tumor lysis, or it could just be because you're dehydrated. And you're going to have often, though not always, have an elevation in LDH. And where do you get the LDH from? Cell turnover. Can you diagnose anything with LDH? No, it's about as helpful as an ESR, right? Can you diagnose anything with an ESR? No. Okay. You're going to treat this with multi-phase chemotherapy, induction, consolidation, maintenance. Therapy is going to last a long time, 3.5 years for boys, 2.5 years for girls. We treat boys longer because they don't do as well. Part of that is thought to be that they have an extra sanctuary space, which gives them risk, and that's the testes. Both boys and girls do have one sanctuary space that requires special treatment, and that's the central nervous system. And we do that by giving chemotherapy intrathecally, okay? 50 years ago, before we did intrathecal therapy, 60 years ago, people did not survive leukemia. It came back in their spinal fluid. Okay. Prognosis for ALL is excellent. I think everybody would quote 90s. You have a worse prognosis if you're greater than 10. You're automatically considered high risk. If you're less than 1, you have actually a terrible prognosis, or instead of your survival is about 50%, and that's infant ALL, and that is biologically different than, perhaps we'll even give it a different name, but it is different from regular ALL. If you have that 922 Philadelphia translocation, if you think back to medical school, the translocation that defines CML, you can also see it in ALL, and we call that Philadelphia positive ALL. Historically, those patients did worse, but now in the day and age of tyrosine kinase inhibitors, those patients do pretty darn well, and we don't even have to take them to transplant necessarily. So that's good. This is a disease that we don't transplant patients for, okay? We cure them with chemotherapy. We cure them with this long chemotherapy. AML is different. We're kind of getting away from the morphologic classification. You might have learned it in medical school. It's called the French-American-British classification, where they describe AML by different morphologies. I think what is still important about that is that there are two entities within AML which are different. There is M3, which is acute promyelocytic leukemia, also known as APL, and that's associated with a 15-17 translocation. Patients present with horrible DIC. If you can get them through this first month, if you can keep them from having intracranial hemorrhage, if you can keep them from dying, they have about an 85% cure rate. You use all trans retinoic acid in their treatment, okay? It might be something you're familiar with from your basic science learning days. And you also use arsenic trioxide. No one really understands the mechanism of action, but it works, and M3 is a very different disease. M7 is acute megakaryocytic leukemia, and so that's the megakaryocyte producing cells have gone rogue. Children with trisomy 21 have a higher incidence of M7 AML. Signs and symptoms, just like ALL, except you can get that crazy soft tissue involvement. Labs can be the same thing. Treatment, very different. Intensive chemotherapy over like a 6-month time frame. If you've got a really good donor, we might consider transplant right up front. Prognosis nowhere near as good as ALL. Historically, we're kind of stuck at 50%, except for M3, and children with Downs M7 actually tend to do very well if they're young. Downs children less than 4 with M7 do well. Okay, let's do another question. 4-year-old boy, new to your care, eczema, intermittent thrombocytopenia, recurrent infections, weight loss, fever, night sweats, severe constipation, physical exam reveals cervical nodes, and a CT shows a 10 by 8 by 9 centimeter abdominal mass, which of the following is false? Okay, I left a -1 in here. But again, I like them in some ways just for my teaching, so bear with me. Okay. All right. So false. Again, this is tricky. So we're going to make all these statements true. If you've got an underlying immune deficiency, you're at risk for lymphoma. End of story, okay? What does this kid have, probably? What's got Aldrich? Yeah. Presence of B symptoms. If you've got fever, weight loss, night sweats, that's bad, okay? That makes you higher risk in Hodgkin's, okay? Surgery does not have a role in treating lymphomas. They respond very well to chemotherapy. And the only role for surgery is to make a diagnosis, to get a piece of tissue. Lymphomas, yep, they can be driven by EBV infections. Very fascinating. It opens up the possibility for some interesting immunotherapies down the line. 7-year-old girl presents with a 6-week history of right submandibular lymphadenopathy. She's been treated with 2 courses of antibiotics without resolution, but is otherwise healthy. No fever, no night sweats. Physical exam reveals a 4-centimeter node. Her PPD is that, and her catch-scratch disease testing came back negative. What is the most valuable diagnostic test that you're going to do right now? Channel your inner Willie Sutton. Rob the bank. Find the right answer. Go to the bank, get your answer. All right, excellent, okay. So, first of all, let's just take a quick digression, and I promise it'll be quickest. How many of you think this child was horribly mismanaged? They waited 6 weeks, and they gave her 2 courses of antibiotics. Raise your hand if you think that was horrible mismanagement. I'm glad nobody's raising their hand, because there's no right way to do lymph nodes, I think. I mean, there are only 2 tests that are ever definitive for sorting out a problem with whether a lymph node is malignant or not. You either can wait it out or cut it out, okay? And we can't cut everything out, right? I mean, you just can't do it. So, a child who's otherwise pretty well appearing, you're going to wait this thing out. So, now, could you argue that you needed the 2 courses of antibiotics? Most of these are reactive, and the antibiotics aren't going to help. But, come on, it's not perfect medicine. But yeah, a little Keflex, a little cephalexin, a little clindamycin, a little whatever is not a horrible idea. When we go to do the Willie Sutton test, the things that are going to make us do it is the size of the node, the location of the node, and the history of the node, as well as other symptoms. So, like I told you earlier on, the 1-centimeter node is dung. A 4-centimeter node, that starts paying attention. Okay? So that's why we're going to cut it out. And interestingly, and this is a smaller little issue, is that you have to cut lymph nodes out. You don't get diagnoses by sticking needles in them, okay? It just doesn't work. Because if you think about what a lymphoma is, it's malignancy taking over the lymph node. And what you want to see is, if you think back to your basic pathology classes, basic pathology classes, and remember how beautiful lymph nodes are. Their architecture is so organized. They have germinal centers. They're beautiful. When you see a lymphoma, that architecture is destroyed. There are sometimes, I've heard my pathologists say that they can diagnose nodular sclerosing Hodgkin lymphoma, the most common type of Hodgkin lymphoma, from low power. They'll just see the sclerotic bands running through it, And so again, you're not going to get that visualization of architecture if you don't take the whole lymph node out. So lymphoma, you got to diagnose from biopsy. We can split lymphoma into Hodgkin lymphoma, also called Hodgkin's disease, or non-Hodgkin lymphoma. Hodgkin lymphoma and non-Hodgkin lymphoma occur about the same rate in children. Hodgkin's lymphoma is typically seen in older children. This 7-year-old I described in that study was kind of based on a patient I knew very well who ended up with Hodgkin lymphoma. The youngest I've ever seen it in is 3, but it is classically the disease of the AYA population, adolescents and young adults. Non-Hodgkin's lymphoma, it tends to be much more acute. These patients tend to be much sicker. So the sick kids, I tend to be thinking they're going to have non-Hodgkin lymphoma. Hodgkin, like I said, similar in incidence. That you can think of, like if you're walking into your teenager with night sweats, weight loss, lymphadenopathy, supraclavicular lymphadenopathy, that should make you worry. Neck nodes and going down here to the clavicle, that should make you think Hodgkin's. It tends to move nodal group to nodal group. Okay. Nodular sclerosing is the most common pathology. That's the most common type you see. That's part of classical Hodgkin. Epidemiologically, it can be associated with Epstein-Barr virus and immunodeficiency. Signs and symptoms we've talked about. I find it fascinating. I still remember it from medical school. It probably isn't worth mentioning, but I still think it's so curious I'm going to mention. That patients can present with itching and alcohol-induced pain. Hopefully we're not seeing that too much in our teenage population. You can also see paraneoplastic syndromes, which include ITP, immune thrombocytopenia, and AIHA, autoimmune hemolytic anemia. Okay. All right. Labs are often normal. We do ESRs and CRPs, sometimes as weak, wimpy markers of disease, but ESRs and CRPs are not specific. It's a disease that we treat typically with chemotherapy and radiation. I should really be a plus-minus radiation. We're trying to get away from using radiation. I don't think management questions are going to be things that you're going to be asked, other than maybe understanding, what some of the late effects of those therapies are. Non-Hodgkin lymphoma is a very heterogeneous group of diseases. You have both B-cell lymphomas, T-cell lymphomas. Probably the most notorious non-Hodgkin's lymphoma is Burkitt. These can present with fever, fatigue, lymphadenopathy, sometimes big belly masses. They tend to grow fast, and they can, have TLS, tumor lysis syndrome, or they can present with superior vena cava syndrome, compressing the vena cava, the puffy face. In Burkitt's, because these big abdominal masses might be invading a bowel wall, they can lead to intestinal perforation. Labs, often are very normal, though you might see some elevations in uric acid and LDH. Non-Hodgkin's lymphomas are different in that they require CNS treatment, because they're a little more like leukemias, and they typically require a little bit of CNS treatment. Prognosis is generally good, but it varies with stage and with the particular type as well. Non-Hodgkin lymphoma can be incredibly memorable. This is a picture of one of my patients with an abdominal Burkitt's. And this is a kid who ended up with a perforation and amazingly survived, got all his therapy in, recovered from his perforation, got all his therapy in, and did phenomenally well. This is not something you'll likely have to know, but I just think it's pretty cool. I love pathology. I always go see these guys, and right there in the middle of the screen, you see the owl looking at you, and that's classic for Hodgkin lymphoma. Brain tumors. Okay. What have we learned today? We've learned about looking for diamonds among dung, right? We've learned about robbing banks, okay? And now we're going to learn about real estate, okay? All right, we'll get back to that. 9-year-old girl complains of clumsiness for 1 week and headaches for 1 month. Her physical exam reveals right dysmetria and left upper and lower extremity weakness and numbness to pinprick. The most appropriate evaluation to establish the patient's diagnosis is what? We're going to tap her, we're going to do an MRI, we're going to do nerve conduction velocities, we're going to do an EEG, are we going to do a urine tox screen? Now, again, this is where Willie Sutton does kind of come into play is, well, if I'd made her 19, okay, I think you get a urine tox screen on every 19-year-old, right? But being silly. But, again, avoid the temptation to pick a test that is something you might do when there's something diagnostic that you're going to do or something that's going to influence your decision. So you're going to get an MRI on this kid. 6-year-old boy comes to the ED for ataxia, decreased activity, difficulty speaking, and facial droop. The patient has also had crossed eyes. I took this right out of an HPI. The mother first noticed he was having difficulty keeping up with his karate class for the past month, increased difficulty with walking, some slurring of speech, and facial droop. So he's having difficulty speaking, he's got crossed eyes, and he's got facial droop. Crossed eyes, facial droop. What is the most likely diagnosis? Okay, think about neurosciences in medical school. You should answer this question just based on your ability to know something about neuroanatomy. So if you got those things going on, you've got a problem in the brain stem, okay? And this is an example of a brain stem glioma, sometimes also called a diffuse infiltrating pontine glioma. Basically, should your pons be this fat? No. Should your pons have diffuse signal changes? No. This is a really bad brain tumor. This is one where when we explain the diagnosis, we need to make sure that everybody in the room is crying, because if they're not, they haven't understood. Okay? All right. Brain tumors are a really big category. They include the benign, low-grade astrocytomas, okay? Things like a JPA, a juvenile pilocytic astrocytoma. And they also include malignant tumors like medulloblastoma, which grows typically in the posterior fossa, and high-grade glioma. Okay? Where do most brain tumors occur in children? Above the tentorium or below the tentorium? Below, exactly. What about adults? It's the opposite, right? What about children? If you get something in the noggin, is it primary or is it a met? Primary. Adults, met. Okay. So again, we have a whole slew of things in here. They are lumped together in oncology, the most common solid tumors. They can show up with anything: headaches, vomiting, seizures, clumsiness. They can sometimes be diagnosed when somebody gets in head imaging for an unrelated issue. The diagnosis is by pathology, except for the brainstem glioma, or the DIPG, which is something you make basically just based on imaging. We've started to biopsy DIPGs, but there's always concern about the risk of hemorrhage, and that's going to be really bad if you hemorrhage in your brainstem. Treatment for brain tumors: the best treatment for a brain tumor, or the most important part of a brain tumor treatment, is surgery. Okay, for every brain tumor, the prognosis is better if the surgeon cut it all out, whether it's low grade or high grade. The best brain tumor is the one that's gone, okay? Sometimes radiation is appropriate. Sometimes chemotherapy is appropriate. Sometimes all you need is surgery, okay? Prognosis. Prognosis is highly dependent on two things: location and histology. And I guess I'd like to just do a quick little teaching point regarding that comment on location. That's where I made the real estate comment. What do they say the three most important things in real estate are? Location, 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 right? And so that's what makes that's really critical kind of in sorting out and thinking about brain tumors, okay? I mean, everybody's taught almost overtaught, I would argue, in medical school about craniopharyngiomas. Please raise your hand if you did not learn about a craniopharyngioma in medical school. Did not. Okay. Everybody learns about them because they talk about it, and then they talk about the visual field effects, right? It's, we got to talk about it. And I'm very frustrated about how, as an oncologist, about how craniopharyngiomas are taught. Benign or malignant? Probably taught to you as benign, right? Oh, yeah, it's benign. Okay. Is there anything benign about how a craniopharyngioma behaves? No. I mean, these kids can end up with horrible pituitary, function. They can end up with, just their whole hypothalamic pituitary axis trashed. And, diabetes insipidus in a teenager, does that have potential to be bad? Yes, that has potential for significant morbidity and mortality. So I like to think of craniopharyngiomas as illustrating the point of real estate. Location, location, location really matters. That histology, the histology is, quote, benign, but the location makes the behavior really, I would argue, anything but benign. Okay. Solid tumors. I love solid tumors. When I was before being at North Carolina, I did all my training at Baylor College of Medicine, residency, fellowship, and then faculty for, I think, 7 years. And I was mostly a solid tumor guy there, so I love solid tumors. And the way I like to teach solid tumors is I like you to be able to match the story to the tumor, because I think that's how you're going to get your questions right. Okay, it's actually how I make diagnoses too. 3-year-old girl, evaluation of fussiness, low-grade fever, bone pain, refusal to bear weight, physical exam, non-tender mass in the right periumbilical area, also a little mild purple discoloration of the eyelids. That's kind of a little bonus. So we got a 3-year-old who is sick. Okay, this is a kid who doesn't feel well, ill-appearing child, bone pain, doesn't want to bear weight, fussy, all those things. Okay, so which of these tumors is the story of the fussy, sick kid going to be associated with? Okay, all right. Yes, you should also think about intussusception, but that's not the right answer because we're in the oncology lecture. But yeah, you ought to think about with a fussy kid, whether they have intussusception. But, having some discoloration of the eyelids is not a classic. So the ill-appearing child, the stories we're going to match this to is neuroblastoma. Conversely, let's turn around and talk about this child. Hey, doing pretty well. Mom, grandma was watching him one night. The classic test question always is the grandma watching him. Finds this mass while she's bathing him, comes to the office. You get a blood pressure. Not every pediatrician does, but you decide you want to. And he wasn't screaming and yelling and kicking, and you got that blood pressure. And, you look at him, you hadn't seen this kid before. He's new to your practice. You're wondering, man, that head looks a little small, and that tongue looks a little big. I remember some things I learned in my training. I'm going to measure leg sizes, and lo and behold, they're different. And UA shows microscopic hematuria. All right, I have put in about as many pieces of that story that I can think of to try to tie it to a diagnosis for you. Okay? All right. This is Wilms tumor, okay? And Wilms tumor is the child who's a little bit more well-appearing. Can a Wilms tumor patient be sick? Oh, yeah, especially if they fall and rupture the tumor. They're going to be sick. But generally speaking, it's the well-appearing child. It's the child who has hypertension and microscopic hematuria. And Wilms tumor can also be associated with certain syndromic features, okay? And we're going to talk about those. But that's how you're going to make that story, okay? Former 26-week preemie. Large, firm, non-tender right upper quadrant mass. Which of these is true? As a former preemie, the patient has an increased risk of hepatoblastoma. Beckwith-Wiedemann syndrome is not associated with an increased risk of hepatoblastoma. AFP is typically elevated in hepatocellular carcinoma, but not in hepatoblastoma. Low serum AFP is a favorable prognostic factor in hepatoblastoma. Hepatoblastoma, I'm on the liver committee in the Children's Oncology group, so it's one of my favorite tumors. It's weird to say you have a favorite tumor, but it's one I know a little bit about. So this question is about hepatoblastoma. And so what you want to learn about hepatoblastoma, if you're going to learn one thing, is you're going to learn that former preemies have an increased risk of hepatoblastoma. So you see preemie, I want you thinking hepatoblastoma. Beckwith-Wiedemann, yeah, you probably have rattled around in your head that Beckwith-Wiedemann is associated with Wilms tumor, but it's also associated with hepatoblastoma. AFP, the one thing that's kind of cool about hepatoblastoma is that it's a tumor that we have a biomarker for. Alpha-fetoprotein is like through the roof typically in this tumor, like hundreds of thousands sometimes, and we can use it as a biomarker to check response to chemotherapy. Low serum AFP in a hepatoblastoma is shown to be associated with poor prognosis. That's kind of like a fellow level question. And I would actually argue that low serum AFP HBs are probably in 5 years not even going to be called hepatoblastoma. Okay. 10-year-old girl, pain in her leg, patients described as growing pains. She complains of recurrent pain unrelated to exercise, sometimes awakens her from sleep. Slightly larger circumference of the left distal femur compared to the right. You obtain a leg radiograph. Okay. Do you see what's going on here? Do you see this stuff? Okay. All right. What's the most likely diagnosis? Okay. Again, you're in the oncology lecture, so I think it's pretty obvious, but I want you to understand why the correct answer is the correct answer. Okay. I can only assume one of two things, that the people who voted E hit the wrong button or they're just trying to pick a fight with me. I don't know. But that's an osteosarcoma, and that is, remember Mr. Codman and his triangle? That was some beautiful Codman triangle. Okay. 6-year-old boy presents to the ED with swelling of the right cheek for 3 weeks. He was prescribed a 1-week course of amoxicillin at an emergent care clinic. He completed his therapy without improvement. The MRI is obtained, and even if you don't know your T2s from your T1s from your, and you couldn't find you can't find anything on an MRI, one thing you can do is always do a symmetry check, right? And this is not good, right? This is different, okay? And so what does this guy have? Does he have a dental abscess? Does he have buccal cellulitis? Does he have a synovial sarcoma, a Ewing sarcoma, or a rhabdomyosarcoma? Where was this? What do you do with these? What gets done over here? Anybody eating? Okay. So where that is in the muscles of mastication, probably. And what you're seeing on that picture is a rhabdomyosarcoma. And do I know that it's a rhabdomyosarcoma? No, not without diagnosis. And could it be another sarcoma? Absolutely. But, the most common soft tissue sarcoma is going to be a rhabdomyosarcoma, a muscle tumor. So let's get our stories straight, okay? Because that's how we're going to do solid tumors. Neuroblastoma, whole lot of variation in presentation, but I want you to think of it often as the sick kid with a mass. Wilms tumor, the well kid with a mass, and I also want you to think about the syndromic links with Wilms tumor. Beckwith-Wiedemann syndrome, Denny-Drash, you need to think about that. Hepatoblastoma, if there's one thing you're going to learn, former preemie. Osteosarcoma, most common bone tumor. I think I have this on another slide, but let's just emphasize it here. Where do 80% of osteosarcomas occur? Distal femur, proximal tibia. They happen near the growth plates. They happen They happen in the decade of life where you're growing the fastest, the second decade of life. Ewing sarcoma is another bone tumor. Not always, though. It can just be soft tissue, but they usually have a bony component. Different from osteo in that they're more likely to show up in the pelvis, and they tend to have a larger soft tissue component. Rhabdomyosarcoma, the most common soft tissue tumor. Oh my God, they can appear everywhere. They can be orbital, they can appear in the prostate, they can appear in the extremities, everywhere. Retinoblastoma. Retinoblastoma, I'm not going to tell you anything about because it is so freaking complicated. The only thing I want you to know is if you see a white eye, I want you to think retinoblastoma. Okay. So we're going to go kind of, again, emphasize the stories. Neuroblastoma is the most common abdominal malignancy. I need to probably put in an epidemiology slide. Leukemia, lymphoma, brain tumors, neuroblastoma, Wilms tumor, okay, when you talk about malignancies in children. Most common abdominal malignancy. You know, it arises from sympathetic tissue, so it can present anywhere you have sympathetic nerve tissue, it can arise from, so it can give you lots of signs and symptoms. You know, it can give you that Horner syndrome, it can give you paraneoplastic syndromes, opsoclonus, myoclonus, the eye movements. It can give you periorbital ecchymoses because really bad, high-risk neuroblastoma likes to go to the bones, and some of the bones it likes are the facial bones. And then you can get these bluish sub-Q nodules that I've never really seen. Treatment depends. Neuroblastoma needs to have two different names because low-risk neuroblastoma can be surgery or it can be observation and the patient gets better. High-risk neuroblastoma is going to be chemotherapy, autologous stem cell transplant, chemotherapy, surgery, autologous stem cell transplant, radiation, and then immunotherapy. If you're from Sloan Kettering, you'll fight about whether the autologous stem cell transplant is needed, but that's standard of care elsewhere in the country. But it's just two very different diseases. Okay. What makes you have low-risk neuroblastoma is if you're young, if your disease is limited to the skin, the bone marrow, and the liver. If you do not have amplification of the MYC oncogene, and if you have lots and lots of chromosomes, a ploidy index of greater than 1.16. Okay. This is a beautiful young girl who I took care of with an intermediate risk neuroblastoma. You know, again, we typically think of neuroblastoma as being a tumor that arises from sympathetic tissue, the most sympathetic tissue being in the adrenal glands, making it the abdominal mass. It doesn't necessarily have to be an abdominal mass. It can arise from sympathetic ganglia in the chest or even in the neck. And so this young lady has Horner syndrome. Can you see it? Okay. Can you see why? Yep. It's like when you learned in medical school the Pancoast tumor in lung cancer. Does that sound familiar to anybody? Okay. This is an MIBG. MIBG is a radioactive chemical that gets taken up by pheochromocytomas and neuroblastomas. And these black spotches are areas of disease. And so this is a patient with high-risk, widespread stage 4 neuroblastoma with all these black dots in the pelvis representing bone/bone marrow involvement. Wilms tumor is the second most common abdominal malignancy. It's about 450 cases in the United States a year. Again, I want you to think about dysmorphic features and syndromes with Wilms tumor. Generally, these children are more well-appearing compared to children with neuroblastoma. Very, very treatable disease. Typically surgery, chemotherapy, and plus minus radiation. I just love my pictures and my path, so that's a scan. I've never seen a small Wilms tumor. You might hear this referred to as a claw sign, okay? Because what you see is that this is arising from the kidney and that the kidney is stretched out, encasing this. This is not a tumor that's crushing the kidney. This is a tumor growing out of the kidney, and you can see that with this claw sign, okay? This is a beautiful picture from pathology. Soft tissue sarcomas. I use rhabdo as the example. Rhabdo is the most common. The other soft tissue sarcomas are sometimes referred to as non-rhabdo soft tissue sarcomas, and they're rare and varied, and many oncologists don't know a whole lot about them, so I don't want you to. Rhabdo can come from a whole variety of sites. The orbits, genitourinary, like I said, I have a young boy with a prostate one right now. Muscles in the extremities, parameningeal, and other head and neck locations as well. Anything that gets in the sinuses is called parameningeal and a little riskier. Surgery, radiation, chemo, generally a pretty good prognosis determined by stage and histology. They're called, some have embryonal histology, some have alveolar histology. Alveolar is much worse. It's also defined now by a particular translocation. So we sometimes call them translocation negative. Those are better. Translocation positive are worse. Okay, that's all I want you to know about retinoblastoma. Okay. Well, actually, you know what? I shouldn't be quite so harsh. It can be inherited. Bilateral disease, I want you to think of as being inherited, as a germline mutation in the RB gene. Okay. For the guys who follow you next year, I think I find neuroblastoma so hard that I don't like to tackle it in my own life. But so I think white eye and can be associated with germline mutations. Okay. And then and that germline mutations more frequently show up as bilateral disease. Okay. Bone tumors. The two big bone tumors are osteosarcoma and Ewing. These are tumors that occur in the second decade of life when the patients are growing. We talked about where osteos can be. Ewing's can be in more places. The most important thing, a couple things about this. The most important thing that we need to do in an osteosarcoma is cut it out, okay? And in Ewing, we like to cut it out, but if we can't, we can radiate it and get success. The way I think about these is that a couple things. One is, it may sound kind of strange, but we don't stage these. It's very binary. You either have a localized tumor or you have metastatic disease. If you have a localized tumor, the cure rate's about 70 to 80-ish%, And if you have a metastatic tumor, the cure rate's about 20% or less, okay? And we think about the treatment of them as being local control, and that's the surgery, cutting the tumor out, or the radiation, radiating the tumor. And then we think about systemic control as medicines that we're using to prevent the tumor from coming back in a metastatic or new location. And you have to use systemic therapy. That experiment's been done. We used to, long ago they did amputations for osteosarcoma and they cured patients, but they only cured about 20% of them. The rest, even though they didn't see any disease, outside of what they amputated, those patients still had their tumors come back. Fortunately, these diseases don't always require amputation now. There are a lot of fancy surgical techniques that can be done to do limb-sparing surgeries, and you've probably seen kids with all kinds of cool prostheses. Okay. All right. Hepatoblastoma. If you're going to learn one thing, it's associated with prematurity. Now listen, premature infants have a whole hell of a lot bigger problems than the risk of hepatoblastoma. Okay? I don't want you to leave here thinking, oh my God, every preemie I need to be concerned about. Well, we don't do it routinely, but maybe in the future we should check AFPs on preemies. AFP is going to be high when you're really young, but when you get out to a year, your AFP should be normal, okay? And if it isn't, then you probably have a hepatoblastoma. Premature infants have about a 40-fold increased relative risk of hepatoblastoma, okay? They still got, that's relative risk. There are only about 100 hepatoblastomas in the country each year, 100, 150, okay? But, so again, it's not the biggest problem, but it's something that I think merits knowing. It's a good-looking picture of a hepatoblastoma on an MRI in the liver, where it is, where they grow, okay? Survivorship, okay? Things pediatricians need to know about patients who are treated for cancer, all right? You're evaluating a 17-year-old girl with a 2-week history of headache and morning vomiting, okay? Morning vomiting, code word, okay, right? At age 3, she was treated for T-cell ALL. Back then, when she did it, and maybe even still now, we felt like she needed cranial radiation. She wasn't going to be just good enough with LPs. We gave her cranial radiation. Did a good job treating her leukemia, but it's now created a problem. She's got headaches and vomiting, okay? What do you guys need to do to evaluate her headache and vomiting? You're going to get an MRI. Now, the reason you're going to get an MRI is, you might have picked lumbar puncture. Oh, is her T-cell leukemia back? At 14 years, probably not. Probably very low risk. What you're worried about is you're worried about a brain tumor. We're going to talk about that in a little bit. Okay. This question was asked to me on an in-service or some kind of, or maybe my board exam. It was like one of the first questions, and I smiled and I chuckled and like, this is on the general pediatrics exam? Because it was like something that I think about a lot, but then I thought about it and like, yeah, we ought to make sure our general pediatricians think about that. You're following a 17-year-old boy who was treated for Ewing sarcoma as an 11-year-old. His treatment included 300 or 375 milligrams per meter squared of doxorubicin. That's a big dose, okay? His annual echocardiogram shows a significant decrease in LV shortening fraction. What is the most appropriate step in his management, okay? So the question is, do you get another echo? Do you do a MUGA scan? Do you biopsy him? Do you start an ACE inhibitor? Or do you initiate therapy with a diuretic? Okay, all right. So there's really a couple parts to this. It's like knowing what does the anthracycline do, okay? And then how do you like to treat the problem that the anthracycline is causing? So what this anthracycline is causing, and I need to probably rethink this question because this is the first time the majority of the group has not gotten it correctly. So let's talk about this. What do anthracyclines do? They cause anthracycline-induced cardiomyopathy. What does that mean? They affect the squeeze, okay? Right. So I don't want to repeat an echocardiogram in 3 months. He's got a problem now. I've always learned that a MUGA and a good echo are the same, okay? So you're not going to get anything different out of the MUGA. If he's bad on shortening fraction on his echo, he's going to be bad on his injection fraction on his MUGA. Myocardial biopsy, I don't know. I've never seen one. I've never seen it done for this. I've heard it talked about maybe, but don't do a lot, right? I mean, I don't see those happening in kids very much. I don't see them happening in adults. We know that we've given this kid a drug that's going to affect his squeeze, and now we're starting to see problems with that squeeze. So what do we need to do? We need to do something about it. And so this goes back to medical school, or maybe your cardiologists, you've done enough cardiology that you pick this up, but what do you do with heart failure? ACE inhibitors are really important because they do two things, right? They reduce afterload, right? And they also, through changing how genes are expressed, also have impacts, right, on cardiovascular remodeling. So starting him on an ACE inhibitor is a really important thing. Okay. 9-year-old boy, short stature, T-cell ALL at age 3, less than third percentile for age, and his dad is 6'4", and his mom is 5'11". He's Tanner stage 1. What is most likely to be abnormal for this guy? Okay. All right. Okay, it's going to be his growth hormone, right? And it's hard, you're right, I mean, I can see some of the other answers, but the reason that, you're going to focus on growth hormone here is at 9, and what we're telling you, about his Tanner and his sexual maturity rating is that this is not going to be, this is not a problem of sexual maturation or of those issues. He's 9, okay? If he was older, that might lead you in that direction in answering the question. Okay. So survivorship overview, radiation. Remember our first question? That young lady had a meningioma, okay? Guaranteed. You get craniospinal radiation, you're going to have a high risk of meningioma. You can also get high-grade glioma. I still remember when I was a med student. I met this young man who was a college student in follow-up for his T-cell lymphoma, doing great. He'd gotten radiation. I remember meeting him again in his fellow when he was dying of his GBM. So the classic tumor, the most common is a meningioma, low grade, but with cranial radiation, you can also get GBM. Your hormone effects are going to get screwed up. Growth hormone is probably the most common. Infertility, if you're going to radiate the testes or the ovaries. Chemotherapy really ain't much better. You have a higher risk of secondary leukemia, typically AML, with a drug called etoposide, but you can also get it with cyclophosphamide or any of the alkylating DNA damaging agents. If you just think about it, you're damaging DNA, you're going to bump that risk up. Almost every cancer patient has some mild kidney issues, especially true after the drug cisplatin. And the alkylators, the DNA damaging drugs, are going to really increase your risk of infertility. There are also some other changes that just happen. Cancer survivors tend to have more problems with obesity, metabolic syndrome. They have increased risk of heart disease, especially with anthracyclines and radiation. They have some liver dysfunction, often associated when they've had a lot of methotrexate. They're at an increased risk for second cancers just in general. And long-term follow-up of these patients is absolutely critical. 1 in 300 young adults is going to be a survivor of childhood cancer. There are a few things in not cancer that I think you need to recognize. You got a 16-year-old obese girl who's on isotretinoin for her acne. She's got a really bad headache, pulsating sounds in both ears. You see the papilledema, which, boy, I'm not very good at seeing. But the remainder of your exam, including a thorough neurologic evaluation, is normal, okay? Do we need to get the MRI? Does she have that brainstem glioma? What do you think she has, and what might you want to do about it? Exactly. This is the classic pseudotumor. 11-year-old boy with seizure disorder on valproic acid. He's got a fever, mildly ill, but he doesn't have any lymphadenopathy, organomegaly, or skin lesions. Looks pretty good. He's got a normal creatinine, but he's got a little bit of thrombocytopenia. Why does he have thrombocytopenia? I don't know. Does he have acute lymphoid leukemia? He's only got one cell line down. That's a big jump. Does he have hemolytic uremic syndrome? I don't know. He's not really having any hemolysis and he have uremia. No, he's got drug-induced thrombocytopenia. He does not have ITP, likely, because usually when we think about ITP, when you've seen ITP, especially when you think about it, where are your platelets? Often really, really low, right? Can you have ITP and still have 98? Yeah, but it's hard to even make that call. This is likely a drug effect. You'll often see the anti-epileptic drugs cause thrombocytopenia. You'll see them cause neutropenia as well. So always think that. So in the not cancer category, I want you to think about pseudotumor cerebri, which can happen with obesity, vitamin A overdose, medications. The retinoids are vitamin A analogs, and it's going to get better if you do a lumbar puncture. There are a bunch of different bony lesions. I think one of them that kind of has a classic story is the osteoid osteoma. It's a very radiolucent lesion with some sclerosis around it, and that's going to get better with NSAIDs. Fibrous cortical defects are sharply demarcated, typically found in the metaphysis, and they generally regress. Have you heard of ABCs, aneurysmal bone cysts? They can look pretty ugly on an X-ray, but they're bubbly kind of looking. But they don't have, you're not going to see a Codman's triangle, those kind of things. You need to know that drugs can be myelosuppressive, and someone taking a drug with mild myelosuppression is something you need to think about. And then going back to hematology, you need to remember that the bone marrow failure syndromes are not really a cancer. So again, try to keep an eye out for the diamonds. There's a lot of material on oncology, but a lot of it's, but there are going to be very few questions. So try to identify those things that are really high yield or maybe make for a clever question. And again, I really, I hope you kick butt on your exams and that this has been helpful to you on some level. I appreciate your attentiveness this morning. It's been great.